So I want to say thank you to Joy and Apple for putting this panel together following that amazing research. And I also want to start by saying this is going to be a conversation, and I want to allow for really substantive time to go back out to the audience, because I'm sure a lot of you took in a lot of that information and have some questions for Dr. Kim, but also for our speakers after we have a chat. So I'm going to introduce Dr. Kim, you've already heard from. Aracely Navaro, we're so delighted that you could join us. Moira is not able to join us, so we're lucky Aracely could step in. She is the Associate Director of Government and Community Relations for the Children's Partnership here in Los Angeles. So she'll be bringing the policy perspective to this conversation. And then Dr. Rahil Briggs, who runs Healthy Steps, which is a national initiative housed at 0 to 3. And Dr. Briggs is also a close partner and friend of Ascends. She has been a real leader in the 2-gen field, including in her prior role at Montefiore Medical Center in New York City. So I want to kick off by giving a little context and framing for what 2-generation approaches look like and are. And Ascend is a nonprofit program of the nonprofit nonpartisan Aspen Institute, which is based in Washington, D.C. And that's important because it was started about a decade ago, and 2-generation approaches are at the heart of what we do, but they are by no means a new concept. You can go back to settlement houses at the turn of the 20th century to see some of the themes of 2-generation approaches emerging. I'm a clinical social worker by training, as you heard from Apple, but I've been at Ascend since 2010 because in my clinical work, where I worked in inpatient settings and at an alternative to incarceration for women who'd been sentenced to Rikers Island and separated from their children, I became increasingly frustrated by the systems that these women were in and the limitations that I had in doing psychodynamic and therapeutic work with them. This is generally the point where I give a spiel about what 2-gen is, but I'm going to do something a little different because we have hot off the press, almost literally, a new report from the Frameworks Institute. I'm not sure how many of you are familiar with that organization, but we over the last year have commissioned research from Frameworks to help us sharpen and essentially redefine for the field what a 2-generation approach looks like. And so I'm going to read to you the guidance they shared with us about how to communicate this work to broader audiences, and in particular what it looks like in the public sector. So for America to eliminate poverty and advance broader well-being, significant changes are needed to the ways in which public policy, public programs, and support services are arranged, funded, and implemented. 2-generation or whole family approaches have emerged as a way that governments can better deploy public resources devoted to early learning, education, employment, health, housing, and nutrition, making the most of these funds by using them more strategically. The 2-generation approach involves identifying the factors that undermine a family's overall well-being and then working with the family to solve problems, access new resources, and sharpen existing skills. A responsive, holistic, family-centered mindset differs significantly from the dominant current approach to public anti-poverty efforts, which rely on a dizzying array of discrete programs, each focused on a specific piece of the poverty puzzle, and each limited to people of a certain age, a certain income level, or other characteristic. Now, thank you. I have to say I shared this with my 19-year-old niece, who was like, "That's your big idea? How can we not do that already?" So just goes to show you that the younger generation is already on board. Couple things I want to note before turning to Dr. Kim with my first question. One, this is about systems not working for families, not families failing. I think this message is also about inherent worthiness and dignity. It's not about who deserves what and when. The other thing I want to note is 2-gen is an imperfect term. We recognize, particularly in indigenous communities, that many of these approaches go 7 generations deep. So we use 2-generation because it is a way of us getting at the evidence around dyadic treatment and where certain innovations are emerging in early childhood and post-secondary education, for example. But I also want to note that with a racial equity lens, other terms are used and are important. And then the last thing I want to note is that in this conversation, as Dr. Kim made the case, we are talking about families with low incomes. We know in the United States that about 44% of all children are living in a family with a low income right now. We know that the racial wealth gap is significant, but we also know that biases exist in the system across income level, and I think Stephen's story really poignantly shows that. So that's a little bit of the context for this conversation, and I want to start with Dr. Kim, since we just left off with you. Can you talk a little bit about how your research, and also your colleague, Dr. Wadamura, who's one of our fellows, regarding neural changes to maternal and infant brains, how do you think that this presents opportunities to meet the needs of children and their parents simultaneously? What do you see as, in the research field, an opportunity to go deeper to learn more about how we can influence practice and policy with it?
So yes, thank you. I think, as a person who do, basic science research, I'm really, welcome to the feedback, people who are doing the policy work. But from the scientific point of view, I think, the amount of the changes in the brain indicates that this is a developmental period for an individual. Right? And if it is learning and developmental period, it should come with the appropriate support, just how, we like to support children's brain development. So, because the mother's brain is so plastic, it goes through a really large degree of development. I think it highlights that two-generation approach. That the mothers need the support from others and have opportunity to also show that their own resilience and strengths.
Thank you. So I want everyone in the audience to be thinking about a question I'm going to ask the next two panelists. And that is, what research do you think is missing that would help make the case for the work you are trying to do? Because something that Dr. Kim and I talked about before the panel is that she's presenting research that she is doing, but there may be areas where you actually need more evidence that would be helpful to note for her and for other researchers in the room. But I'm going to go to Dr. Briggs next and talk a little bit about Healthy Steps. So we know that Healthy Steps presents a significant opportunity to maximize the window of opportunity based on the research we've heard. Can you tell us a little bit about the overall goals of Healthy Steps and talk also about the evidence that you're seeing that it's improving outcomes for families?
Sure. Thank you, Sarah, and thank you to Joy and 2020 Mom for having us. The basic idea behind Healthy Steps, which is a national program now in 23 states, Puerto Rico and DC, serving about 250,000 kids and families a year, and on our way to serving 1 million children and families, is that the pediatric practice is an extraordinary platform from which to engage not just children but their parents. Parents bring their children to the pediatric practice. They don't arrive on the school bus. They're not coming on their own. They're always coming with their parents. And whether you look at the data about prenatal care or that postnatal 6-week postpartum checkup, the rates of moms going to prenatal care or that postpartum 6-week checkup are always lower, no matter the group you're looking at, no matter the state, no matter the racial, ethnic, socioeconomic group, versus the likelihood that those same parents will bring their child to the pediatrician. So what an awesome platform to engage in a two-gen, multi-gen way. The idea behind Healthy Steps is that you add a new team member, so it's team-based care in pediatrics, recognizing that pediatricians have about 15 minutes in which to do a well-child visit, and they're asked to do everything under the sun in those 15 minutes, and to really do the kind of relationship-based parent-child work that we're talking about needs more than that, and it's not really realistic to ask the pediatrician alone to do that. So it's team-based care, adding a new team member to the pediatric practice. The vast majority of Healthy Step specialists are licensed clinical social workers or doctoral level psychologists, so this is mental health care for babies and parents together within the pediatric platform. You have 12 to 13 well child visits in the first 3 years of life, 7 in the first year of life, And again, about 90% of folks regularly attend those visits. The Pediatric platform is a trusted, non-stigmatized platform. I'm a child psychologist. Talk about stigma. Nobody wants to bring their child to a child psychologist. But as soon as I went and partnered with the pediatrician, nobody said no. So we have a risk stratified way of working with families so that there are both universal services for anyone who walks into the practice, no matter your background, your insurance. All families receive social determinants of health screening and maternal depression screening and child screening, and then risk stratified levels of intervention based on family need. In terms of evidence, there was a national RCT, and there have been multiple site-level studies since then that have shown everything from increases in well-child visit attendance, decreases in emergency room visits, but more importantly, maybe for our conversation today, increases in screening for maternal depression and decreases in maternal depression symptoms. Looking at mothers who have experienced trauma in their own childhoods or adverse childhood experiences, looking at the intergenerational impact on their own children, seeing a real break, a positive break, so that that generational trauma isn't then recreated. I think the best way to sort of tell you about it, I have pages and pages of research findings, but it was such a wonderful talk by Dr. Kim. You can, I'll share these with you if you're really fascinated by that. I want to quickly just tell you more from a parent's perspective what this looks like. This is actually from a healthy step specialist in Queens, New York, and she just sent this to me. She said, I met this family when they came in for their newborn son's first visit. They seemed like a happy family, told me all about their 3-year-old daughter who was excited to meet her baby brother. Over the course of the next few visits, it became clear they were not as happy as they had seemed on that first day. Dad moved out shortly after the baby was born. Mom was on her own with 2 kids during the week, and Dad took them on the weekends. As Mom became more comfortable talking to me, Mom opened up about her relationship with her own mother, how confusing and scary her childhood had been. Her mother was mentally ill, behaved in ways that a child could not understand. She had taken Mom to New York from Georgia and left her with her grandmother. Mom felt abandoned, and as any child would, and had no understanding of why any of this had happened. She eventually made her way to the foster care system. You can imagine what that was like. And Mom now found herself being told what a terrible mother she was by her ex without any family support and not ever having experienced a positive parent-child relationship. She questioned herself as a parent. She questioned her worth. During this year, she'd experienced a panic attack so severe she thought she was dying and called 911. She also had thoughts of suicide at times, though she was able to contract with me. Mom and I discussed going to therapy on many occasions, and while she wasn't totally opposed to it and acknowledged that she needed help, she didn't take me up on any of these referrals. But luckily, she was willing to talk to me during all of the well-child visits and in visits in between those. We've worked through a lot of her self-doubt and questions about whether she's a good mother. Recently, there was a particularly bad fight. She was at a very low point. We were able to set her up with a mental health screening with one of our therapists that same day, and I got to play with her kids during the appointment. Over the past year, I've watched Mom become self-confident, patient, much more in tune with not only her children, but her own needs. Mom takes time to teach her daughter the kind of behavior she expects instead of yelling at her. And most importantly, Mom values herself and sees the importance of her own life and wants to keep living it. She's started taking new steps to overcome her anxiety and depression and is an extraordinary role model for overcoming adversity, challenging stigma, confronting mental health challenges, and taking care of herself in order to take care of her children as best she can. So the basic idea not being, should we do this in OB or peds or psychiatry? We need to do it everywhere. The stakes are too high to argue about where this should happen. This is about integrating behavioral health in the places that families go when they're looking for care.
Thank you. And I think you've also modeled really well how important it is for us when we're making the case for these approaches to have both the quantitative and the qualitative data, because the data and the evidence is important, but the stories matter so much too. Aracely, I want to go to you and talk a little bit specifically about systems change and policy. And it's wonderful to have you on this panel because at Ascend, our theory of change around the two-generation approach is that research and evidence plus parent expertise and voice plus best and next practice informs policy and systems change. So I feel like we've had a natural progression to your perspective. So the Children's Partnership has been instrumental in California in advancing a range of policies for families, not just with low incomes, but with low incomes as well. And I'm curious, how have you applied or are thinking about a two-generation approach in your policy efforts? And then specifically, what lessons are you thinking about from the brain science that Dr. Kim has highlighted or other brain science that has been out there over the last 5 years?
Yeah, thank you so much for having me. This is exactly from a policy lens. What we're hoping to do is that intersectionality between the research, the community, and policy. So we have been working really hard to think about this work. One of the ways, well, let me step back. In terms of social determinants of health, for us, it has been the populations, thinking about the most vulnerable in our state, thinking of the 9 million kids in California, half of them in Medi-Cal. So we do focus on the systems and thinking about how they can better serve children and families. And one of the big research pieces we did that ties very well into this work was immigration policy. We are not immigration policy, immigrants' rights organizations, but we saw immigration policy having an impact on children's health. And so it was having an impact on the toxic stress levels. It was having an impact on their academic success. And so we've been thinking about the research. So in terms of gaps, thinking about where some of that research can come to help parallel with all of the other research that's happening that is impacting kids, children and families' well-being. A lot of it very in line with the ACEs model and again, in terms of what children and families need. So we started doing a lot of research in that space, which complemented a lot of the work that's happening here. And I think for us, it is about making systems work for kids at all levels. And so in terms of the work we've been doing, it has culminated in systems change. So in California, we're very fortunate to have a Surgeon General now, which is a whole new model in the country who focuses on ACEs. And so in this new budget cycle, there is a proposal to come up with a curriculum on ACEs, which is, I think, what that looks like. Fortunately, advocates will play a role in that. But really thinking about what is coming from the research, what is coming from models, to really think through to help people understand what this means. So that's one mechanism. The governor is also an early childhood champion. One of the things that we also want to make sure, in addition to education, often is the case or the vehicle that people think of early childhood, changes a programmatic system. We think health is the one that needs to also be integrated. So really, again, really thinking about that whole child and what the child and family needs. So really, in the budget, again, there is a department of early childhood that's proposed. And for us, again, the advocacy of that intersection between health, education, and social programs. So we're really excited about that. And then in terms of the Children's Partnership, based on research we have done, based on taking into account some of the brain research for both children and pregnant women, we are actually introducing legislation on streamlining enrollment for those who are already in WIC but not eligible, because the system is not in place. They're eligible for Medi-Cal, but they're not enrolled. And so how can we, from behind the scenes, change the system to help families and pregnant women, and again, taking those barriers away from all the stressors that they have in their life? Where can a system, and I really like what you said around making sure that we, the systems are failing us, our families. It's not the individual. So this is an attempt to really streamline enrollment from WIC to Medi-Cal for children and pregnant women. We've had bipartisan support for 2 years. It came down to the money in the last 2 cycles. So this year, we've introduced legislation to really start with the low-hanging fruit of those who are already in the system, and then making sure that we streamline it. The other one I would like to mention about thinking about the whole family and the needs is around medical legal partnerships. There are many that exist in California. There are others that we've learned best practices from in other states. And this is the co-locating or co-integration of medical lawyers or legal assistants in a medical space. So again, that warm handoff, that a non-traditional way of integrating. Our long-term goal is that Medicaid pays for it as a benefit. So of course, in this current environment, we're not moving that forward, but in the legislature and through the budget process, we are going to be advancing that. And then lastly, on the mental health, because kids were internalizing a lot of the stress, it was showing up. We did research on how the immigration policy work was having an impact on the children's, citizen or not, on their mental and behavioral health. They were showing up with stomach aches. They didn't want to come to school, their academic success. So we passed a bill, AB 2315, which looks to bring mental health and behavioral health to a school campus. So there is, the term is telehealth. And really thinking about what that model looks like. We really want to, integrate nurses. For us, it is a whole system of people, and it really is bringing care to where kids are to move away from the stigma, to make it accessible as we work on the workforce issues. So I'll stop there.
That's great, thank you. And I should say California actually has one of the largest numbers of Ascend Network partners. Our network is focused on mobilizing and partnering with organizations that want to do 2-gen approaches or work. We have 30 network partners in the state of California. There's an amazing organization here in Los Angeles, the Los Angeles Valley College, which is a community college, but they have created a very robust program for student parents with a strong mental health component, looking at that population. So we are frequently looking to California for inspiration right now. I want to ask another set of questions of the group and then actually go out to all of you. So we have about 20 minutes or so for Q&A. It's 2020, and we have an economy that's going very well, but not for everyone. We have a potentially historic, historic presidential election taking place in November. I think that there has been significant reduction in the stigma around mental health, but we have a long ways to go. So I'm curious, from each of your perches, research, practice, policy, and Rahil, you're sort of at the intersection of practice and policy, where do you see the greatest opportunity to impact families right now? Maybe I'll start with you.
Thank you. So to me, I think, again, like providing the environment for all mothers to parent their children that is safe and supportive. So one of the things that I think it would be important would be, for example, like paid parental leave, that the duration is appropriate for building really deep emotional bonds. And something we see in our data, and I noticed there are some other reports, is that, now we study mothers from the first trimester and the postpartum period, and there is a really deep in their income level right around the childbirth, especially for low-income women, because they're working at a places that there's no parental leave policy, not to even mention paid leave. The only option they have is to quit their job, and especially mother who's also a single mother, doesn't have a partner who can provide income. they were already at a low income status, and then their status really dipped right around time. And I can only imagine the kind of stress and adversity that they have to experience during this period of time. And then the other part is, I think what we just talked about, I recently heard a very powerful analogy that used by a professor at the UNC, that how perhaps in the system we treat our pregnant woman like a candy wrapper. So candy being a baby, that during the pregnancy you pay all attention to the pregnant woman because of that candy. But once the candy is out of the wrapper, what do we usually do with the candy wrapper? We just toss it away. So all the other attentions and the policy support in some regard, like a Medicaid, are focusing more on babies rather than the postpartum women who are still dealing with the medical issues and the mental issues. So I think those will be some of the focuses for the future.
Thank you.
For us, definitely, the census is a big factor for 2020 as well. Children are actually the most undercounted, have been the most undercounted population. So certainly for us, it's that intersection between informing community and letting them know what it means. So the long term is it changes congressional seats for California. Again, representation of our population. And also, it has implications for long-term investments in terms of the population. And so the other is for them to know their rights, both healthcare rights, both legal rights. There is proposals to changing, laws and such, but the chilling effect has been really impactful, again, on a toxic stress level to our children and families. So really thinking about what truly is law and what is proposed. We've had to do a lot of educating and engaging families and understanding what a regulation versus a proposed bill versus a budget is, and which is part of the civic duty, I think, as well. So, so we're exploring ways of, again, as we do our community engagement, to make sure that families know what they're protected by, and then as well, how to get informed, engaged.
Thank you, Aracely, for giving two, because I felt bad that I was going to be cheating, but you laid the groundwork for me. Payment for prevention is a critical piece. We struggle in this country. We pay when you have a diagnosis in mental health, and we do not pay when you don't have a diagnosis. And what's been pretty extraordinary over the last couple years is that the Healthy Steps National Office, in conjunction with Manat Health, we've developed a business case that shows that year over year, you've got a very positive return on investment when you intervene in this two-generation way. Across 4 different states now, looking at an average return on investment of about 200%. Invest $1, get $2 back. How does that happen? Well, the kids are more likely to be vaccinated and go to the dentist, but mom's more likely to get attention for maternal depression and interpersonal violence. Payment remains a challenge, and what I have started to think a lot about, and especially being here in California, where I don't know if you all realize what an extraordinary time it is in your state from not being in California and looking into California. It's like, wow, this is a real moment, with a governor who's committed to early childhood and a Surgeon General who's committed to ACEs and the like. $69 for every developmental screening and $29 for every ACEs screening will be paid in California by Medi-Cal. That more than pays for a program like Healthy Steps, which only costs $100 per family per year. Our data systems, though, I know this isn't sexy, but stick with me for just a second. Our data systems do not allow for you as a pediatric practice to extract the data that shows that you did those screenings. right? Epic has 50% of the market share. This isn't a knock on Epic, but they're just the biggest. So when you're out in front, you get things thrown at you, right? You cannot document a child developmental screening and ACEs screening, much less a maternal depression or an anxiety screen in a standard template. And if you can't document that screening, then you can't pull out proof that you did those screenings, then you can't pull down that $69 or $29, and you lose this extraordinary opportunity because people say, well, hold on, we paid $69 or $29 and nobody did the screenings. Nobody was able to extract the screenings from their medical record system. So I think we have to stay focused on payment, but also really recognize the barrier that the data system creates for showing what was done, extracting it, and pulling down that payment.
And I think that granularity is actually really, really important because it's where the rubber hits the road when we're talking about, big frameworks and approaches. How does it get done? And I will say, there's huge momentum for two-generation approaches across the country. The biggest challenge for us to move out of a proof of concept phase into, demonstrating that this is evidence-based is around the data. And not that there isn't emerging, there aren't emerging outcomes for children and the adults in their lives, but how do we integrate that data to show that it's correlative and causal? So we have not fully cracked that nut, although we are actively working on it. I want to go out to the group because you've heard a lot of us talking, and I'm sure you have a lot of questions. And as we move into Q&A, I just have two quick requests. One is that you introduce yourself and tell us who you are and your affiliation. And the second is that, if possible, to avoid using acronyms when you ask your question or share your comment, because we're all coming from different perspectives and expertise. Who's up?
Okay, we collected the questions, actually.
Oh,
so
excellent.
people will not be able to introduce themselves. Sorry about that. And we're going to go back and forth between questions in person and online as well.
Perfect.
So here's the first one that we have for the policy person. Who are you paying closest attention to in the governor's proposed budgets? Biggest impacts, and what should we focus on? Small question.
Hard. Yeah. As stated, I mean, this is a governor who is changing systems. There's, and I apologize, but they just changed the name, the CalAIM system. It's essentially the reform of Medi-Cal, of DHCS and the systems. And so there is work groups, and one of our challenges with this new effort of changing how Medi-Cal functions in California is that it comes from a high-risk whole child, whole person lens. And we want to make the argument that we should come from a prevention space, that we should not wait until kids are high need, high risk users, which are more costly. The data shows such case, and really think about from a prevention lens, what can our state do? There's a slew of items under that category. There is also, for us, it's in talking about 2Gen is Health for All. So Health for All is another big, long-standing effort that's been happening in California. We were able to get Medi-Cal full scope for kids in 2016 up to the age of 19. Last year in the budget up to the age of 26, and this year we're hoping to include seniors. So in really 0 to 3 has actually done research on the benefits of having grandparents covered and the implications, in terms of that to a whole family and as child caretakers, as family members, and again from a lens of just humanity. So there is the element of the ACEs curriculum. There is other efforts around developmental screenings. So we're monitoring a lot. And then, as I mentioned, the additional pieces that we will be asking for in the budget are tied to legislation.
Great, thank you.
All right, here's another question, and this is asking, in the research where mothers with reduced brain response, what other types of behavior was observed?
So the behaviors that I focused on in that study was looking at the mother's interaction with her own baby. And unfortunately, during that short period of time that we were observing the mothers, on average, that the reduced brain response was related to less sensitive. So the way that we measure is like, how many times she smiled appropriately in the interaction, how many times that she spoke appropriately in that context with the baby. So those are what we observed. The mothers who tend to participate in this study are, even though they're in the very stressful environment, but they are otherwise doing pretty well. And the next step that we focused on is studying the mothers who are relatively struggling even more. That, like, for example, mothers in the clinical level of depression. So that will be the next step. Mm-hmm.
Great. So this is from someone who's either streaming or on a webcast. This is Whitney Plantia. First of all, said that the candor wrapper analogy was really helpful and a great analogy, unfortunately, I guess. But the question is, do you see changes in the Violence Against Women Act impacting higher stress levels and increased ACE or risk scores?
Policy.
Yeah, I mean, yeah, okay. So apparently there's a panel, so please check that one out. But I would say yes. I mean, again, just based on what we're seeing, and again, I make the parallels to immigration policy because family separation, when we think about the ACE metrics, we TCP argue that immigration is one of those metrics that's not accounted for. And it's because of the family separation. So again, some of the trends and behaviors that happen as a result of policy, so in terms of the act, if at minimum, I would say the chilling effect implications of what it could mean has an implication on health. And so I could anticipate that, but most definitely I defer to the group tomorrow.
I would just add that with our network, the Adverse Childhood Experiences study and the way in which it's been rolled out has been very, very powerful for a lot of organizations looking to do 2-gen work. I mean, what Nadine Burke-Harris has done over the last 5 years is really incredible. I would say that we have a lot of partners who acknowledge that it's a tool, and if you want to use the tool well, you have to have investments in professional development and staff time and training and, understanding of secondary trauma. So I think when we talk about ACEs, we need to be mindful too of the way in which there has to be an ecosystem in an organization to support what comes out of using the tool.
Great, thank you. This is another question from online from Vanessa Lopez in Stanislaus County. Is there a research study that provides information on return on investment when providing mothers with the mental health needed to secure parenting, reduce the stress, and increase bonding?
So an ROI on the investment in maternal mental health, essentially for both generations. Do you want to talk a little bit about that?
Sure. As I mentioned, this business case work that's done is looking at the cost to the state Medicaid authority when maternal depression goes untreated, and then comparing that to when you're able to go ahead and treat that. As I said, when you're looking at a 200% return on investment, the vast majority of that is on the mother side. You're not recouping a lot of ROI on the child side because kids are pretty cheap to start with. They don't cost the system a lot of money, right? So there's been a lot of effort that really looks at the costs to the system. It's monetizing something that most importantly is a cost to a family and is at a human level. But in terms of the data and the research, we have to sometimes look at it in terms of a cost level. And you can see that 12-month year-over-year cost savings when you're able to intervene on the maternal depression. I think, as Stephen very accurately said, we also need to expand our focus to anxiety, the acronym being PMADS, the maternal, the parental PMADS, perinatal, all at once now, perinatal mood and anxiety disorders, to really recognize the full breadth of what folks are looking at.
Thank you. And I would just add to that, too, across the 2-gen field, there are some programs like one coming out of Head Start called Career Advance in Tulsa, Oklahoma, where this is a long randomized control trial looking at parents who are enrolled in intensive mental health as well as workforce training, and then the control group of parents who are not. And that study is showing that the attendance rates of the children of parents in the Career Advance program, which has a mental health wraparound, are higher than the attendance rates of children of parents who are not. The hypothesis being that child outcomes may improve when their parents have access to those supports. Again, it's very intuitive, but that's the kind of evidence that we need related to the question. Other questions?
Thank you. Yes, we have lots of questions. Thank you all. Oh, no. 10 minutes, yeah, 5 minutes. We won't get to all of them. We'll do our best. So this question is asking about the intersection between brain structure, behaviors, and environments, and says, how do we account for the unique strengths that also exist in low-income families? And as a second part of that, how do we account for different cultural expressions of attachment between mothers and babies?
I'm happy to take a piece of that, but I think Dr. Kim can speak very intelligently to it as well. Epigenetics is so important, and epigenetics being the intersection between environment and genetics. Looking at basically, you can have a genetic predisposition for something, say schizophrenia, and the environment that you're in has an influence on whether or not that happens. Most importantly, we're learning so much about the differences between children when they're born and their risk susceptibility. Anyone who has more than one child knows that they kind of came out probably a little different from day one, right? One cried more and was harder to drop off at kindergarten and just was more fussy, and the other one kind of nothing phases that kid. The orchid and dandelion metaphor that's been put forward by Tom Boyce and other wonderful researchers, not a perfect metaphor. We're not either all orchids or dandelions, a continuum, but being the idea that you are somewhere along this very resilient, not that susceptible to the environment, i.e. a dandelion. Dandelions grow in the cracks and they grow anywhere, but they're always kind of going to be dandelions, right? Or exquisitely sensitive, the orchid. And in the right environment, the orchid blooms. And in a challenging environment, the orchid really suffers. There are vast strengths in families, and poverty alone is not in and of itself, a necessary barrier to children really flourishing. I grew up in Colorado. That poverty level was way above where my family was. I grew up in the poorest county in Colorado. I get to be the national director of Healthy Steps, right? Was I a dandelion? Maybe, but I also had an extraordinary preschool system, and there was a doula at my birth, and there was a real focus on early childhood. So it's just to say we're learning so much about the individual differences that really seem to be from birth and from the perinatal environment potentially that are really helping us understand which children and families might benefit from the most intense interventions.
That's an excellent question. So in terms of resilience, the most of studies more focused on children's resilience, and the couple things that from that literature has been pointed again and again are supportive parenting and higher cognitive functioning. So for mothers, the resiliency literature has been more limited, but the thing about the kind of cumulative risk that I talked about, the other side of that, the mother is having more stressor means that they have a less resources to use to cope with, like less resiliency. So I think the focus should be then, finding the ways that, not all mothers develop postpartum depression. So those mothers, who do relatively well in a difficult situation, for example, like what are some strengths that they have in them can be, their childhood background and so on. I think will be really important things to study. And in terms of the mothers from the different cultural background, I think that's something that really needs to be understood better, that there is a system that I feel like not giving the equal right to all mothers to have the children that they want, not to have the children, or to parent a child in the environment that they would really like. So, immigrant parents, parents with the minority background, I feel like, some testings, like, when the child's birth, whether the child will be tested for the drug or not, I think it's a good example of how that's done without the mother's consent, and it's done for only selected mothers, which increase the risk for mothers to lose the baby. I think this is just some of the examples that there's a system that we have that put a lot of mothers in an even more disadvantaged position and not having the right that they deserve. So I think those are really important questions. Mm-hmm.
So we have a question at the back that I know we want to get to.
I've been waiting patiently. My name is Heather. I'm from First 5 Ventura County, and I felt a need to speak up today in the absence of Moira from the association not being here. And I know that the majority of the folks in this room are focused on moms, particularly, obviously. But on behalf of First 5, and this is mostly targeted at our policy person up there, but the prevention is the key, and you spoke to the work that's being done in the K-12 system, but again, that doesn't always get to the littlest ones. And we know that that's directly connected to the mothers who are experiencing postpartum depression, et cetera, and the attachment that's formed with our youngest children, that's not necessarily being discussed yet. I think in addition to that, there is this, California is at fault for this, actually, but this medical necessity that comes out of our behavioral health systems that is never intended to be targeted at the youngest children, and our 0 to 5 population is continuously left out of that system, right? And while some of those systems may not need to target the child specifically, back to the 2-generation approach about doing things with the youngest children and their mothers, locally in Ventura County, we're doing these parent-child together classes, and that's what it's intended to do, is to bring any caregiver with their child to give parents a forum and caregivers a forum in which they can connect to other people and reduce the social isolation that happens, in addition to getting education for their children and the bond that's happening directly with the parent and child. So I just ask that we continue to stay focused on the youngest children too, and not forget that there's a vast majority of children who are not in the K-12 system, and the preschoolers are struggling in our systems. They have challenging behavior that, again, the behavioral health systems are not addressing, and so.
Thank you. No, I think that's a really important reminder. I don't know if, Aracely, you had anything you wanted to respond to.
No, most definitely. So I didn't get to 2 other parts of our build portfolio. So actually, our president is on the Mental Health Commission for California, and one of her intentions is to really bring to light that children and that 0 to 3, 0 to 5 component is often missing in the conversation. And in terms of thinking about early childhood centers and entities that support children, pregnant women, and families overall, we are working on legislation to think about what the information, training, and services are available there to raise the elevation. And I imagine the ACE curriculum will be also a place where we will advocate to make sure that it accounts for that population.
And also not just low-income families, right? Because we know that all these kids who are not connected to the Medi-Cal system are still having other issues that happen, and they get left out. Even when there are changes to the system at that level, they still get left out of that larger circle.
Yes.
Just very quickly, we have so much focus in this country on universal pre-K, like that's going to solve all these problems, right? We have all these children showing up to kindergarten not ready to learn, and somehow just moving that 1 year forward is going to solve all of our problems, when actually what we're going to have is a lot of children showing up to pre-K not ready to learn. For your exact point, that this real opportunity, back to this really moment and window of opportunity, is within these first 3 years of life.
Thank you. Well, I think that that is our cue to transition to the break. I want to give a round of applause for our fantastic speakers. Thank you. And just make two quick notes. One is the work of Dr. Kim and her colleague Sarah Watamura are found in multiple places, but notably in a report called Two Open Windows, which is available on our website, and it captures not just some of the research she shared, but also some practice and policy recommendations. So you can find that on our website, and I'll share it with Apple for the app. And then the second thing I wanted to note is at Ascend, we have an innovation community called the Aspen Family Prosperity Innovation Community. It is supported by the Robert Wood Johnson Foundation. Last week, we released a letter of intent, and we're seeking responses for a $2.6 million fund. We are seeking to fund up to 20 organizations around the country that are working at the intersection of work-family supportive policies, mental health, employment, childcare, on behalf of families with low income. So I suspect there is some of that work happening in this room, and you can go to our website to learn more about that funding opportunity. Thank you so much.
Thank you, Sarah, and the rest of the panelists for this very engaging conversations. As a pediatric therapist myself at a children's hospital, I can really attest to the urgency of the two-generation approach.